Next in our webinar series, Let's Talk About Epilepsy Surgery, we have a special webinar for Infantile Spasms Awareness Week. And we're here today with Dr. Aria Fallah, who's the director of the Pediatric Epilepsy Surgery Program at UCLA, and Dr. Shaun Hussain, who's the director of the Infantile Spasms Program at UCLA. And we're going to talk about epilepsy surgery for infantile spasms. Welcome.
Thanks for having us.
Yeah, thank you for joining us. Dr. Hussain, could you talk a little bit about sort of the history of epilepsy surgery for infantile spasms and when that started? It's my understanding that it was sort of a relatively new concept in about the early 90s.
Yeah, so unfortunately, patients with infantile spasms were late to the game when it came to the option to have epilepsy surgery. And that really stems from the fact that it's hard to figure out where infantile spasms come from. In contrast to other seizures that are more common in adults, infantile spasms really spread very quickly, and they are often coming from lesions in the brain that are hard to see. So it's much less obvious than cases in older children or adults, and it takes a lot more technology and different ways of looking at the brain to find out where infantile spasms are coming from. And if you don't know where they're coming from, you won't even think about surgery.
And they're a generalized seizure, right?
Well, not really. Yeah, probably all seizures are focal in some sense. And infantile spasms very much look generalized, meaning that they appear to begin in the entire brain at the same time. But that's because they likely start in one place, but are then rebroadcast to the entire brain very quickly after the onset, within less than a second. And that speed with which it generalizes or spreads in the brain is a big obstacle to figuring out where they come from. And again, when you don't know where seizures are coming from, you don't think about taking out pieces of brain.
Can we talk a little bit about infantile spasms? I know that parents watching this are pretty familiar with it, but I think it's important to really go over, their severity and what they do and what the risk factors are.
Sure. Well, infantile spasms are obviously a severe form of epilepsy. They are the most common epilepsy syndrome in the first year of life. And, our existing therapies, medical or surgical, are simply not good enough. There's a huge unmet need in the community. And that really reflects some of the statistics you see here. We cure about 15 to 20% of patients, but that's a small minority. And those are the patients who generally respond to initial medical therapy or get prompt and successful surgery. The remaining patients face incredible risk of other forms of epilepsy like Lennox-Gastaut syndrome, high risk of intellectual disability, autism, risk of SUDEP, sudden unprovoked death in epilepsy. These are pretty scary outcomes. And I think that a lot of the parents and advocates who are listening to this webinar are already quite well aware of this landscape, but it's pretty imposing.
And they unfortunately have such a benign name. I know when parents are first entering the world, they'll say, oh, it's just this thing called a baby spasm. And those of us advocating for the community have to say, well, hold on, these are really almost the worst kind of seizure a child can have.
Yeah, I would say actually the worst. This is not the epilepsy you'd pick if you had to choose. And I think the nomenclature and the naming we've used is a challenge, but we're stuck with it. I think it's going to be easier to explain our way out of it than to try to reinvent the terms here.
Yeah.
And when we think about long-term development, there are a couple key things that can give you some prediction of the future. And the big determinants of long-term outcome are the underlying cause of the disease. And it's kind of interesting that the patients who do the very best are the patients for whom we can't even figure out the cause. And despite new technologies, that's still about 20 or 30% of patients, and those are the patients you want to be. So there's this strange paradox where your doctor is doing a whole bunch of tests, and your hope is that despite all that technology and testing, that the doctor still can't figure it out. And that's the situation in which patients do the very best. And those are the patients who respond to medications the best. Those are not the patients who end up needing surgery, though. Other key determinants are how fast you get a hold of infantile spasms, meaning how quickly do you recognize that they're seizures, number one. How quickly do you get diagnosed and get a prescription for an appropriate first-line therapy, like prednisolone, ACTH, or vigabatrin. Unfortunately, there is a huge knowledge gap out there among the general public, but more importantly, among healthcare providers, general pediatricians, emergency room physicians, and even neurologists. Not everybody remembers infantile spasms when they're thinking about a new patient, and that leads to critical failures in prompt care.
They can look so mild. We just did the awareness video for Infantile Spasms Awareness Week this year. And one of the things we tried to capture was just how subtle they can be. Just these little head nods coming down, but in clusters, which just looks like a little head drop, can be catastrophic. And you can kind of understand why, especially, family members might say, oh, it's nothing, it's just reflux, or an emergency room doctor might say that, but it's so important for parents to advocate and push for diagnosis, because as you say, the quicker you diagnose, the quicker you can treat, even if it's with surgery.
Yeah, that is absolutely true. And it's tough. It's so easy to see these seemingly mild events and talk yourself out of thinking that it's important or dangerous or reason for an emergency room visit.
Yeah. And then third, so the third point is that the younger the child gets infantile spasms, the higher the risk of delay than the older kids.
Yeah, I mean, this is a statistical association, and patients who begin having infantile spasms before 3 months of age tend to do worse long term. But this is not really concrete statistics. There are plenty of patients who violate this rule. And, you don't throw in the towel if your kid has infantile spasms before 3 months. And it's really no reason to relax or take it easy if your kid had spasms afterward. I think the number one thing to be alarmed here about is just having infantile spasms at all and not responding to treatment.
Go to the next slide, where we're going to talk a little bit about all the conditions that can cause infantile spasms. I was surprised to see this list. It's so many different etiologies.
Yeah, and this is actually an abbreviated list. And I think the takeaway message here is that pretty much anything that hurts the brain can be a potential cause of infantile spasms. We don't know why that is, but it's clear that anything in the right situation can be a cause. And probably the reality here is that the patients who actually get infantile spasms with any of these diseases probably have some other genetic predisposition to have infantile spasms to begin with. But again, even that genetic predisposition is not well known. But among the top causes, things like hypoxic ischemic encephalopathy or having brain injury because of insufficient blood or oxygen to the brain, that is a huge cause. Several genetic causes are very common, like Down syndrome, tuberous sclerosis. But again, here's just a massive laundry list of potential causes of infantile spasms. But for the purposes of this talk, we should really focus on the brain malformations, because these are the main causes of infantile spasms that should lead people to think about the possibility of brain surgery. And top among that list would be focal cortical dysplasia. And this is a relatively subtle lesion in the brain, or a relatively subtle structural abnormality. And by that I mean it's the sort of thing that people routinely miss. If you're not up to date with infantile spasms and thinking about it as a possible diagnosis for a patient, when you look at that patient's MRI with a focal cortical dysplasia, it's very likely that you will think it's normal. And it is not the exception, but almost the rule, that patients come from outside centers with what seem to be focal infantile spasms, and they have been told that their MRI is normal. And then when they get to UCLA or another tertiary surgical center, that's when people really scrutinize those supposedly normal MRIs and find these relatively subtle lesions like focal cortical dysplasia. And until you make that connection or make that leap, you don't think about surgery for infantile spasms, and you just cause more delay and reduce the odds of having a reasonable developmental outcome.
We were really lucky in our journey. Our son was born with hemimegalencephaly, and the malformation was so massive. We saw it right away, and he failed 5 drugs by the time he was 2 months old, and we had to put him into a phenobarbital-induced coma. And I remember as he came to, the spasms started again. So we knew very early on that he would need surgery. But I know there are a lot of other families in our community who say, oh my gosh, the doctor said the MRI looks good. And you're saying, hold on a second, you might need to go to another center and do another MRI or with a more qualified team because they may have missed something.
Yeah, I wouldn't even say the word qualified. It's all about experience. And in considering any therapy for infantile spasms, whether it's medical therapy or surgical therapy, you've got to ask your physician, well, how many times have you used this particular therapy in the last year? And if you get an answer like 0 or 1, that should be a pretty clear message that you got to get a second opinion and at least get to a center where they are kind of well versed in the available therapies and really have a good handle on which patients are good candidates for which therapies.
Okay. Could we talk a little bit about then when we start to think about resection surgery? And we'll have another webinar next about all the various types of surgeries where we'll do deeper dives. But a resection is when you cut out or remove part of the brain. And Dr. Fallah, could you kind of walk us through when it would be appropriate to do that for a child with infantile spasms?
Yeah, so any child for which, we tried the first line therapies and then continue to have infantile spasms, we think of it as it's almost the best way to think of it is a neurological emergency. And especially in a setting where we have an abnormality on the MRI or PET scan or one of the imaging techniques where we see a reason, a structural reason for having infantile spasms, we really want to consider surgery right away because, similar to seizures that are not responding to medications, sometimes situations in which the infantile spasms are really, really difficult to treat are some of the best cases for surgery where we can achieve a really, really good outcome. There's really no reason to delay. There's something else that I just wanted to add on to our previous discussion about the MRI is to keep in mind that children's brains are going through a process called myelination in the first couple years of life. What that means in practical terms is that these abnormalities in the brain can be very difficult to find, especially closer to about a year of age. So sometimes if a child has an MRI right after birth or shortly after birth, these spots are better seen. Closer to about a year of age or so, they're very difficult to see. And then after that, they sometimes reappear. So sometimes even though one MRI may not be enough, repeated MRIs can be helpful.
Okay. So what about kids that have a metabolic or degenerative disease? This says that really they are not candidates for resection. Is that right?
Yes, in general, from the list that you had there, genetic, other than, tuberous sclerosis, that is a genetic cause of epilepsy for which we commonly may consider epilepsy surgery, but in general, genetic causes or metabolic causes, they tend to involve the entire brain, and it doesn't, a strategy to remove a portion of it isn't really successful. So we don't really consider surgery in those children.
And what about kids that have conditions that are generally known to be drug resistant, like, there's a small exception, but most children with hemimegalencephaly or cortical dysplasia or stroke will have drug resistant seizures. Do you have to wait for drug resistance to be shown, or should the family start looking into having a phase 1 evaluation sort of as all this is happening so that they know whether the child will be a candidate once drug resistance is established?
That's a great question. We commonly encounter that because we know, statistically speaking, when we see an abnormality on the MRI, the chances of medications working long-term are low. They're not 0, but they're low. All of us are following certain patients in our practice that have an abnormal MRI scan, but are not having any spasms or seizures. But overall, that probability is low. it becomes more challenging to follow, and I should say the standard of care is to not do any surgeries unless the child is having clinical spasms. Having said that, certain situations where the child is following behind their developmental milestones, especially if they're regressing, are situations where, although it's controversial, you may want to get a surgical opinion, because in certain situations, it may be best to take care of the problem early for many reasons. One, because doing surgery on a younger child will allow for a greater ability to recover from surgery, and we take advantage of neuroplasticity, which means the brain has its own ability to rewire. And we also know that we want to prevent any further developmental delay or regression. But I must say that there's not a whole lot of evidence supporting that strategy. So the decisions have to be made on an individual basis, and and that's why we do this in a team setting.
Yeah, I would echo that exactly, that you have to think about these on a case-by-case basis. Certainly in situations like hemimegalencephaly, that is usually a situation in which you have to go for the hemispherotomy as soon as possible. But in entities like cortical dysplasia or stroke, it's not that clear. And there are still quite a few patients who can do well long-term without surgical resection with those disorders. But you always have to just ask yourself, what is the risk of the surgery versus what is the risk of not doing the surgery?
Yeah, that was going to be my next question, or the final sort of piece of this slide, is weighing the risk of surgery, and especially with something like hemispherotomy, where you're going to have a hemiparesis on one side, or a loss of the visual field. You're weighing that, as a parent, versus the catastrophic consequences of infantile spasms. I know for our family it was easy, so to speak, because our son was seizing uncontrollably as an infant, and by then we almost didn't care what the surgery was going to do because the spasms were going to kill him. I think it's really challenging for the parents whose children have good function, or if the spasms aren't, as bad, so to speak, or they're sort of responsive to treatment and they're just coming back, where this can be really hard. I think such a difficult decision for a family to go through.
Yeah, I would emphasize that as scary as the medications are, and as scary as the prospect of epilepsy surgery or hemispherotomy in particular can be, the number one thing to be afraid of is ongoing infantile spasms, even if they're not as severe as they once were. And certainly ongoing electrical abnormalities in the brain, like hypsarrhythmia and variations thereof. Those are the entities to be afraid of, and you really have to leave epilepsy surgery on your short list of options in those situations.
I'll add that, as you mentioned, obviously everything we do in medicine, we have to balance the risks and benefits. Overall, as obviously a hemispherotomy, a large multi-lobar resection, removing or disconnecting several lobes of the brain, is a major operation. But these surgeries are done very routinely and very safely in many of the centers across the country that do these types of cases routinely. So if you're with an experienced team, the risks of something catastrophic happening in the operating room is minimal. It's never zero. It's major brain surgery. Loss of function is something we always consider. It's always easier in a child that has lost some function on the corresponding side of their body that corresponds to the area of brain abnormality. That makes the decision easier. If they don't have that loss of function or that weakness, it makes the decision more challenging. In terms of visual fields or their peripheral vision, so to speak, that's challenging to diagnose in a young child anyway. So that's I'd say it's obviously everything's a concern, but that's a little bit less of a concern than motor function. But absolutely, I mean, you have to be pretty confident to undergo this type of surgery. And the other thing that also adds confidence to your decision to go ahead is whether or not you see an abnormality on that side of the brain. especially if it's a structure abnormality, because you can pretty much predict sooner or later that child will almost certainly require surgery anyway, so you might as well do it sooner.
I think the take-home message is fear the spasms, not the surgery, because the effect of the spasms is going to really be catastrophic in the long run.
Absolutely. The other thing I'll add is, Dr. Hussain and I, we see many patients with this condition, and brain surgery does sound super, super scary to any parent. Sounds scary to many physicians who don't deal with this on a day-to-day basis. But I will tell you the decision most commonly, the families most commonly arrive at the surgical decision. It is seldom where they are so afraid of surgery, and I think it is the right decision. It takes some time to wrap your head around it, but when you see your child continue to have these episodes and these clusters, that decision becomes much more straightforward for many families.
Yeah. What if the child is not a candidate for resection or a multi-lobar disconnection like a hemispherotomy or TPO? Can we talk a little bit about what a corpus callosotomy might mean?
Sure, and as you can see in this picture, we can visualize the corpus callosum, and it's this big bundle of fibers in the middle of the brain that connects the left and the right side. It's the big connection between the two sides of the brain. And I think the instant reaction to cutting this is probably horror for most people, because you're thinking, well, I've got two sides of my brain, I want them to work together, and this structure is key to having them work together. And that reaction is actually accurate and true for older children and adults. This is a really important part of the brain, and you don't want to damage or cut it. If you are a fully functioning adult, you would have tons of problems with your activities of daily living, just looking at things, recognizing things in the world, performing tasks with both sides of the body. But when you think about an infant, that specialization of the brain really hasn't happened, and the extent to which the corpus callosum mediates complicated tasks has not really happened yet. And you can end up severing the corpus callosum as a therapy for infantile spasms without much developmental consequences, especially in comparison to the developmental consequences of ongoing or otherwise uncontrolled infantile spasms and hypsarrhythmia. But it's also not quite clear why this sometimes works. The data is still pretty early. This is a bit controversial in the sense that it's a new strategy out there, and that there certainly isn't consensus that this is an appropriate therapy for infantile spasms. That said, there are now several reports in relatively large patient populations describing substantial benefit in at least a minority of patients. And what we've seen is pretty similar to what is out there in the literature. And our guess is that about a quarter of patients who have uncontrolled infantile spasms and are not candidates for resective surgery, about a quarter of them can actually become seizure-free, at least short-term. And about a third of patients who were deemed not surgical candidates, by cutting the corpus callosum, you can actually isolate the two sides of the brain, and sometimes those seemingly generalized infantile spasms now suddenly appear focal, and those patients are suddenly candidates for resective surgery. And that can be a path to a good long-term outcome. But again, this is balanced against approximately 40% of patients where they really don't see any benefit at all. So it's a kind of a big leap for both parents and physicians to try a seemingly dramatic surgery when there's a pretty decent shot that it won't do anything. But I think you have to be willing to take these kinds of risks and leaps when you're facing the alternative.
Yeah. And this would be, if a resection is not possible, then the parent should have a discussion about whether corpus callosotomy should be explored.
Correct.
Okay. And then last but not least, neurostimulation. So for example, VNS implant, is this something that works for infantile spasms?
Well, it doesn't work well. This is generally a desperation ploy on the part of epileptologists when there aren't better surgical options, when we've exhausted most medical options. There's some theoretical basis for doing this to the extent that the vagal nerve stimulator inhibits or tackles a part of the brain that we think is important for the generation of infantile spasms, which is called the thalamus. But there just has not been robust use of the VNS to treat infantile spasms. And in those limited series out there, really just in patients who were the very hardest to control, the results have not been all that encouraging. It's really a small minority of patients that have seen substantial benefit. Most patients, including most patients at UCLA who've had this procedure for infantile spasms, have not done well. I can think of 2 patients who had robust success out of about 35 patients who've undergone this procedure.
It's a small percentage.
Yeah.
What about deep brain stimulation or responsive neurostimulation, the NeuroPace device?
Correct. So these are 2 newer technologies which are seeking to inhibit that same part of the brain, the thalamus. And we just haven't worked our way down to patients who are young enough to be candidates for this technology and have infantile spasms. I think it's certainly a research interest for the future. And we're kind of getting closer. I mean, there have been several patients who are not quite infants who have had this procedure. But we worry, at least theoretically, about how this device will perform with substantial growth of the brain and skull. But if I had to make a bet, I think we're headed this direction for some patients.
Okay.
Yeah, the other thing to add with especially the DBS and RNS devices, they're only FDA approved in adults. So us even using them in children with other types of epilepsies is investigational at this point. We use it off-label, so to speak. But there's some anatomical concerns as well to place a device in a child so young. Obviously, we're talking about children very young, the first or second year of life, where infantile spasms are most common. And it's important to note that actually the child's brain doubles in size in the first 6 months, doubles again by 2 years of age. So, and when you're talking about the targets that we commonly target for DBS or RNS, they're the thalamus, and these are really, really small targets that are less than a centimeter in total size. So it doesn't, obviously there's limitations, because if you accurately place these electrodes in that part of the brain, I can almost guarantee you by next year of age, the next year that electrode will be pulling out of its where it was intended to be. So it's no longer going to be accurate. So it doesn't mean we can't go back in and reposition it, but obviously, these are all challenges and concerns when we think about applying this type of technology to, really, really young children. There's also the thickness of the skull, and there's other concerns as well that factor in.
That's really important information to know. Thank you so much. I appreciate you joining us today. And this is a really good overview for our families. And perhaps we can have you all come back. I'll put you on the spot for another webinar where we can do a little bit of a deeper dive into some of these technologies. Thank you very much.
Absolutely. It's our pleasure. Thank you for having us and organizing this as well.
Great. Next, we're here with Sarah Sherwood, a mom whose son earlier this year during the pandemic, believe it or not, had a really big surgery to stop his infantile spasms. So thank you, Sarah, for joining us, and let us know your story.
Well, thank you for having me. It's really an honor to be able to speak to families going through this. My name is Sarah Sherwood, and my son Everett had a left functional hemispherotomy earlier this year to stop his infantile spasms that were caused by focal cortical dysplasia on the left hemisphere of his brain. And our story starts back in April of 2019. Everett was just a little younger than 1 year old, and we started seeing him having very kind of suspicious behavior, lasting just a few seconds. His body would kind of crunch up, and his arms would flail out to the sides, and his head would drop, and he would cry. And it was odd movement, but we'd never seen it before. And we had taken him to doctors, and they had told us it was reflux, it was normal baby behavior, and he was getting a couple teeth at that time. So it was one of those, maybe he's fussy because he's teething, and the behavior didn't go away. And I'm a nurse. And something just didn't sit right with me in all of this. It was that feeling, they talk about that mom gut feeling. And we kept going back, and we were finally able about a month after we first started seeing the behaviors to get an appointment with his real pediatrician, his actual doctor. And I'll never forget it. We took him in, and I had captured a cluster of what we now know as infantile spasms on a video earlier in the day. And I took him in and I sat down and I said, I don't know what this is, but this doesn't look right to me. And his pediatrician's watching the video, and Everett kind of sat up on my lap and proceeded to have a cluster of infantile spasms in his office that was followed by a fairly large, what we know now was a focal seizure. His whole body went stiff, his head jerked off to the side, his eyes deviated, and he started to tremble. And as a mom, it's terrifying, absolutely terrifying to hold your child while he seizes. And things happened really quickly. Looking back on it now, the doctor tells me to this day it was about a minute long, and it felt like it was 100 years.
Yeah.
He did come out of the seizure on his own without rescue meds, but that seizure and that activity in the office bought him a ambulance ride to our local hospital and a 5-day stay where it was diagnosed that he had something I had never heard of before called infantile spasms. And if you look on the internet about infantile spasms, it's terrifying. It is catastrophic epilepsy that damages their developing brains. And as a mom and as somebody who knows a little bit of the medical side of things, it was awful and it was scary. And that facility told us his MRI looks good. It's normal. Let's get him started. He was about 1. He was 11 months old. His MRI was normal. His spinal tap was normal. Everything was coming back normal. So let's start him on steroids and let's see what happens. This was April. We did a run of steroids, tried to wean him off and fed them. The spasms came back. We went back up on oral steroids and did a slow wean, and that slow wean seemed to make the spasms go away. September of 2019, the spasms came back. We tried another medication. It didn't do anything, made everything worse. And then we proceeded to try ACTH. It was around this time that we had a second MRI that was again referred to as normal. Genetics seemed to be normal. Everything was normal. They couldn't explain why these relapses kept happening. Surgery was never even discussed. It wasn't brought to us as an option. It was, let's try these medications. If these medications don't work, then we'll try keto. If keto doesn't work, then, we can try some more medications, but we don't know if they'll work or not.
Was additional assessments, were those recommended, like PET scan or SPECT or MEG or anything else? Nothing.
I had mentioned.
Yeah. Just so even though he had also had focal seizures, not just infantile spasms, nobody mentioned there are other assessments we can do.
No, we never up in the initial evaluation periods, the initial treatment period, PET scan was never brought up, SPECT scan was never brought up. It wasn't until after that second/third relapse that I started doing my own research. And in the middle of the night, in a panic, because I couldn't just sit here and watch these seizures take my son, I Googled infantile spasms doctors in California. And the very first person that came up was the doctor that spoke earlier, Dr. Hussain. And I Googled him. I watched every single thing I could find that he had ever done, any talk he'd done, anything I could find. And I knew at that moment that we needed to go to UCLA because I like I said, I couldn't just be okay with let's wait and see, let's see what happens. We could try this, we could try that. I knew that we needed more. So armed with all of our medical records, we went to UCLA, met with a colleague of Dr. Hussain's, and who told us he'd look over all of his records and he would promised us that he wouldn't stop until we found what was causing this. About 2 weeks later, I got a phone call from UCLA saying, we think we see focal cortical dysplasia. We'd like you to come for a pre-surgical evaluation. And of course, in my head, I went, surgery? Well, that was never even told to us. That we were told that wasn't an option. And it's terrifying. It's, as a mom of a child who's now about a year and a half old, I was so scared. But at the same time, somebody had finally taken me seriously and taken the time to look into these scans that were supposedly normal, read over records, and tell us that there was some hope.
Yeah. Surgery is a treatment that in many situations, including your son's and yours, offers hope. And what we're trying to do with this webinar series is obviously not make the decision for anybody. That is up to your family to make the decision, but to make sure we arm you with the knowledge to keep digging further. And your son had hemispherotomy during the pandemic, I remember.
Yes.
Around April or May, right?
Mm-hmm. Yeah. So Everett's, when we went to UCLA for his pre-surgical evaluation, his seizures were stable. He was not actively seizing. They did see some behavior on the EEG that did indicate that the seizure activity or potential seizure activity was still there. But March of this year, the spasms came back for what we call the fourth time. And we went to UCLA in the middle of the very early days of the pandemic, had an EEG, confirmed that epileptic activity, spasm activity, hypsarrhythmia, all of them were back. And that was the middle of March. And on April 6th, we went to UCLA and handed Everett over to the most brilliant team of surgeons we could find and trusted them to perform a very intense brain surgery and hopefully give us the real possibility of a life without seizures.
Yeah, those infantile spasms are bad news. And you know, what we covered a little bit in the previous webinar was 20 years ago, 25 years ago, these kids had no options that had infantile spasms caused by focal cortical dysplasia or other things. And obviously, to anyone listening out there, you don't have to have half the brain removed. Some children have infantile spasms caused by small lesions in the brain, or as the doctors discussed earlier, there are other things you can do. My son also had infantile spasms, so we had him on 5 anti-epileptic drugs at the time. And I remember we had to put him into a phenobarbital-induced coma when he was 3 months old because nothing would stop those spasms. So we were begging for hemispherectomy as soon as possible. And that was 13 years ago, also at UCLA, coincidentally. And they were willing to do it as small as 6 kilos, which was about 13 pounds at the time. There are other hospitals also out there that are great. But I think the message to our parents out there is to keep digging, go in for a second opinion if you need to. We have a surgical evaluation travel scholarship that you can apply for if you need to go to a facility that's further than 50 miles from home, and a whole community here to support you as well. And Sarah, thank you so much for sharing your story.
Of course. Yes.
So in our awareness video for Infantile Spasms Action Week coming up in December 1st through the 7th. So check him out there too. He's adorable.
Yes.
It's really
yes. And I would definitely piggyback on what Monika said. Please don't ever be afraid to seek out a second opinion, to go to a different facility, to do your research, because it could quite honestly save your child's life. So
yeah, great message. Thank you so much for joining us.
Thank you for having me.